Really what we need to do is the clinical studies that prove utility of applying these assays so that they can become part of the standard of care. And so I think one of the exciting but also challenging aspects of this field is that there's so many potential applications. But if we want any one of those to get into the standard of care, one has to show that it actually makes a difference to patient outcome. Just because you can do it doesn't mean it's actually useful, of course. And so we really need to do many studies, well-designed trials that address particular questions. So for example, one thing that we're very interested in is detection of minimal residual disease, where the concept is that in patients who have had, let's say, surgery for early-stage lung cancer, we know that some fraction of those will eventually recur. Well, the lung cancer will come back even though their scans are totally clear after surgery, which means they must have microscopic disease left in their bodies, or what that's also referred to as minimal residual disease. And we have shown that with our assay we can detect which patients have these microscopic cells left. So if you can still detect the circulating tumor DNA after surgery, those patients basically are all guaranteed to recur. Whereas if you don't detect circulating tumor DNA after surgery, the vast majority of patients will not develop recurrence, at least in our initial cohort. And that suggests we might be able to eventually use this to identify which patients need additional systemic treatment after surgery.